Fine, thank you.
Good afternoon, everyone. My name is Dr. Ibiyemi Ilesanmi, and I'll be presenting this paper published in The Lancet D&E in August 2021, titled Cardiovascular Mortality and Kidney Outcomes with GLP1 Receptor Agonist in Patients with Type 2 Diabetes. And it's a meta-analysis of randomized trials. So the SGLT2 inhibitors and GLP1 receptor agonists are two classes of drugs that have been endorsed by the International Endocrinology and Cardiology Society guidelines for management of hyperglycemia in patients with type 2 diabetes and who are at increased risk of cardiovascular disease or have established cardiovascular disease. And as you can see in the highlighted red box, pretty much the three main SGLT2 inhibitors have been endorsed by the society guidelines, whereas for GLP1 receptor agonists, they have endorsed three specific drugs: liraglutide, semaglutide, and dulaglutide, based on evidence in cardiovascular outcome trials. So several cardiovascular outcome trials have shown that patients randomized to receive human-based GLP1 receptor agonists have experienced lower major adverse cardiovascular events, MACE. However, this is not the same for extending 4-based GLP1 agonists. And just to buttress this point, the Excel trial, which was conducted on 14,752 patients, most of who had established cardiovascular disease, were randomized to exenatide once weekly versus placebo, showed pretty much not a nearly significant reduction of 3-point MACE with a hazard ratio of 0.91. So no superiority of exenatide versus placebo. And this is similar to the ELIXIR trial as well, where patients who had recent acute coronary syndrome 6 months before screening visit were randomized to receive lixisenatide or placebo. They showed similar rates of cardiovascular outcomes to Excel. So it pretty much looks like only the human-based GLP-1 receptor agonists have this protective cardiovascular benefit, whilst the extending 4-based GLP-1 receptor agonists do not. And so the aim of this meta-analysis was to update this and to investigate whether a recent extending 4 GLP-1 receptor agonist called F-peglinatide showed any cardiovascular benefit, and to address uncertainties regarding kidney outcomes in GLP-1 receptor agonists, and also to assess for the risks of hospital admissions for heart failure. So the authors set about by doing this, by doing a Medline search up until June 9, 2021, for randomized controlled trials, testing either injectable GLP-1 receptor agonists or oral GLP-1 receptor agonists in patients with type 2 diabetes. And they only included studies with a sample size greater than 500, and only picked studies that included cardiovascular death, non-fatal MI, and non-fatal stroke in their outcomes. Hence, they've ended up with 8 studies included in this meta-analysis. Sorry. So in the analysis, they analyzed for MACE-3, so looking at cardiovascular death, non-fatal MI, and non-fatal stroke, as well as death and admission for heart failure. They also did subgroup analysis of MACE based on age, so less than 65 years versus greater than 65 years, lower BMI versus BMI over 30, baseline EGFR, baseline HbA1c. They also analyzed for drug dosing, so daily GLP-1 receptor agonist versus weekly, and also analyzed for human GLP-1 receptor agonist versus extending 4-based drugs, as well as presence or absence of cardiovascular disease and follow-up period of less than 3 years versus a longer follow-up period. And they also risk stratified patients into risk of cardiovascular disease. For renal composite outcome, they looked at the development of macroalbuminuria, doubling of serum creatinine, or a greater than 40% decline in eGFR, kidney replacement therapy, death due to kidney disease, and also looked at some safety outcomes, which they reported in their appendix. They looked at severe hypoglycemia, retinopathy, pancreatitis, pancreatic cancer, and also collected data for thyroid cancer, which I won't be touching in this presentation. So here's a summary of the 8 studies. So in total, there were 8 trials with 60,080 patients included in this meta-analysis. And just to talk you through this table, there are 3 extending 4 based GLP1 receptor agonists, so lixisenatide, exenatide, and epeglenatide. Sorry, it's very hard to pronounce. And of this, semaglutide was the only oral-based GLP1 receptor agonist. In terms of age, it was pretty similar. Pretty similar age across all trials. The Rewind trial, which looked at dulaglutide, had a greater proportion of females than the other 7 trials. BMI was pretty comparable across the 8 studies. And in terms of baseline HbA1c, Rewind, which used dulaglutide and lixisenatide, had the lowest starting HbA1c. And in terms of established cardiovascular disease, as I mentioned earlier, the ELIXIR trial recruited patients who had acute coronary syndrome months before the trial started. So 100% of those patients had established cardiovascular disease, and the smallest number of patients with cardiovascular disease was the Rewind trial. Heart failure was pretty similar across the board, but Rewind had the smallest number of patients with heart failure. Now, in terms of other drugs that participants were on, insulin, metformin, sulfonylurea, DPP4 inhibitor, and sorry, it doesn't show on this slide, but SGLT2 inhibitor, about 15% of the patient in Amplitude trial, so the epeglenatide, were on an SGLT2 inhibitor. I don't know if that projects at all, really sorry. So that's a little summary of the 8 studies that they included in their meta-analysis. Okay, so now going on to 3-point MACE, cardiovascular death, and fatal or non-fatal MI. You can see that the ELIXIR study does not show any superiority when it comes to MACE. And as I mentioned earlier on, this is a study that recruited patients that had established cardiovascular disease, but also lixisenatide is a short-acting GLP1 receptor agonist and has a really short half-life of 3 hours. And in the ELIXIR study, the patients were only only had once daily dose of lixisenatide, so probably a subtherapeutic dose with once daily injections. So you can see that the relative risk reduction of MACE by this GLP1 receptor agonist is 12%, and the number needed to treat for that is 65. And this is similar for cardiovascular death and non-fatal MI, showing that GLP1 receptor agonists are protective or have shown non-inferiority compared to placebo when it comes to 3-point MACE and fatal or non-fatal myocardial infarction. The authors also did a sensitivity analysis and removed the ELIXIR study, and managed to show that this relative risk reduction was greater after removing the ELIXIR study from the analysis. Okay, so they've also presented data on all-cause mortality as well as hospital admission for heart failure. And you can see here that there's a relative risk reduction of 11% with regard to hospital admission for heart failure. This is nowhere near the same statistics for SGLT2 inhibitor, but the number needed to treat is quite high, so 258 patients. And in terms of composite kidney outcome, including macroalbuminuria, there's a 21% relative risk reduction, and 12%, 14% for worsening of kidney function. So in conclusion, from this table, the authors inferred that GLP-1 receptor agonists reduce the risk of macroalbuminuria by 21% and hospital admission for heart failure by 11%. So this is their subgroup analysis. So again, they looked at MACE outcome in higher, intermediate, and lower cardiovascular risk patients. And they found, again, still protective. Patients with established cardiovascular disease, yes or no. And again, the risk reduction favored GLP-1 receptor agonist. And this is pretty much similar for all the analysis, so looking at HbA1c, duration of follow-up, whether it's daily or weekly dosing. And then we come down to human GLP-1, whether it's a human GLP-1, yes, or an exendin 4-based GLP-1. And you can see that the confidence interval sort of goes across into favoring placebo there, but overall seems to be a protective effect. And I think that this is pretty much the effect of the new study, the F-peglinatide study has added more evidence to this effect. And so in summary, we just wanted to talk about the metabolic effects of GLP-1. So the effects on the pancreas we already know, and in the brain has been shown to reduce both food and water intake in mouse models and in humans. More significantly, in the kidneys, has been shown to increase diuresis and natriuresis in mice and human, although it's not really clear whether there are GLP-1 receptors in the kidneys, and I stand to be corrected, but only one study has shown GLP-1 receptor in proximal tubules of humans. So the mechanisms for GLP-1 receptor agonists being causing natriuresis and improving kidney function is not really clear. So this is a human study where they infused GLP-1 or placebo in 16 obese and 15 healthy subjects. They also gave them an infusion of 2.5% saline and looked at excretion of sodium, chloride, calcium, hydrogen ions, and also looked at renin angiotensin levels in these patients. And you can see that if you compare placebo to GLP-1 infusion, you can see that the sodium excretion is much higher in after GLP-1 infusion, as expected is chloride as well. So we've got two studies that show that GLP-1 does induce natriuresis in humans, but as I said, the mechanism of this is not very clear in comparison to SGLT2 inhibitors, where we know exactly the the physiology of natriuresis in this class of drugs. So in conclusion, from this meta-analysis, we can say that MACE benefits in GLP-1 receptor agonists are independent of the structural basis of the GLP-1 receptor analog, and that GLP-1 receptor agonists have shown a modest, small class benefit to reduce hospitalization from heart failure by 11%. And this is mainly supported by the Harmony and the Amplitude-O trial, which looked at F-peglinatide. And in this trial, with the Amplitude-O trial, they recruited patients with eGFR of less than 25. However, we cannot compare this effect to the benefits that we see in SGLT2 inhibitors with respect to preventing hospitalization from heart failure. So, I mean, it pretty much looks like the MACE benefits or the cardiovascular benefits of GLP-1 receptor agonists are sort of atherosclerotic and via vasodilation, and also via improvement in blood pressure, whereas SGLT2 is mainly by natriuresis and improving hospitalization from heart failure. So that's it. Sorry, I whizzed through that quite quickly. Happy to go back through the slides.
No, that's good. That one, the one with the, did you say 2.5% saline infusion?
Yeah.
It's going salt loading. What?
It is salt loading. The other study, which I haven't shown here, used 0.9% saline. But yeah, this study used 2.5% saline. But also they diluted the GLP-1 in 0.9% saline. So a lot of salt.
Yeah. Still, it's pretty clear what and I wonder why they've done it. Whether they're linked to that last study, the one with the name that we can't pronounce easily.
Sorry, the amplitude, the epiglenotide.
Yeah.
Yeah. So I mean, they have now shown that both exendin 4 based receptor, GLP-1 receptor agonists and human-based GLP-1 receptor agonists have cardiovascular benefit. But I think they're working via two different mechanisms. With SGLT2 inhibitors predominantly causing quite a lot of natriuresis and diuresis, whereas I think GLP-1 receptor agonists, which have been shown to induce vasodilatation, probably work by improving blood pressure and atherosclerosis.
Yeah. Very good. Any other questions or thoughts about this? It fits with what we believe, doesn't it, really?
Yeah. So I think the main outcomes from the meta-analysis are going to just explore the kidney outcomes and to dispel the myths that only human-based GLP-1 receptor agonists have cardiovascular benefit. Because as I said, lixisenatide and exenatide, the trials didn't show any superiority, but they were flawed by the design of the study, recruiting patients with a recent MI. Obviously, they are at risk of repeat, of having another cardiac event or a risk of heart failure.
Yeah. I mean, you do that sometimes purposely, because if you take a high-risk person, a group of high risks, you'd expect the benefit to be bigger. But that what didn't come out in this study at all, did it?
No.
I mean, and this has happened before, a long time ago with rosiglitazone, when they studied it. The high-risk people did really badly. So it can be a dangerous thing to try out. Okay, thank you very much. I don't have any other question from anybody.
No, thank you. That was quite clear. And does it just mean that we carry on
using both?
We carry on using both. And I think in patients with a low, with heart failure or with renal problems, because again, SGLT2 inhibitors have good sort of renal outcomes, you would favor going for an SGLT2 inhibitor. And in a patient who hasn't got heart failure but is at risk of atherosclerotic events, then GLP-1 receptor agonist. But it'll be interesting to see the glucose lowering effect of this epiglenotide. I haven't gone through that study, the Amplitude O trial, so that will be interesting to see. Because both exenatide and lixisenatide haven't really got great sort of HbA1c lowering effect. compared to semaglutide or liraglutide.